Thank you, Javel. Hi, everyone. Um, for those I haven't met, my name's Connor Walsh, he, him pronouns. I'm one of the R2s. Um, Thank you all for being here. Today, our session will be on narrative medicine. Just like briefly, kind of the impetus for this talk. The past year has been really challenging for me personally. I'm feeling the gloom of winter and like the burnout of second year of residency. And I've been like racking my brain trying to figure out how to deal with that a bit better than just like diving into doom scrolling and Netflix after work. Um, Narrative medicine was something in medical school that I took part in a little bit, whether it was writing a bit or just like having more bandwidth for reading. And I found it meaningful and like made work more meaningful. So it helped to get me out of tough moments then. And so I just wanted to share some of that here. Wishing no like burnout and gloom on y'all, but hopefully it's a bit of an outlet. So learning objectives for today's talk. We will define narrative medicine by the end of this. Be able to identify tenets of narrative competence, identify the benefits of narrative medicine to clinical practice and medical education, and then we'll spend some time practicing writing and then sharing our work together. Roadmap for our talk. So I'll spend just about 10 minutes with some introductory slides here to cover some of the basics. And then we'll move into a workshop for about 30 minutes. That will involve some writing here altogether, two activity prompts that I have. And then we will split into breakout rooms that Javel will help us to make happen. And we will share our writing with one another and then have some time to discuss and reflect on it. As we are getting going, to make the breakout rooms easier, if you could all take a second to rename yourselves here on Zoom and just put R1, R2, or R3 in your name. That way, Javel can arrange the breakout rooms for the next few minutes of my slides, and then we'll break out into um, uh, rooms with peers in your like residency class to make some of the sharing maybe a little bit less nerve-wracking. Okay. And then after the workshop, we'll spend about 5 minutes back here in wrap up with a bit of kind of crowdsourced inspiration with a Slido at the end too. Okay. So what is narrative medicine to begin? So the term itself was coined in the year 1996 by Dr. Rita Sharon. She is an internist at Columbia. This is not to say that the concept of narrative within medicine began then, because we've known for millennia, truly, that medicine has been largely based in narrative of illness. Dr. Sharon published this seminal textbook called Narrative Medicine, honoring the stories of illness in that year. And in that textbook, she defines narrative medicine as clinical practice fortified by narrative competence, which is the ability to absorb, metabolize, interpret, and to be moved by stories of illness, which I think even that definition itself is abstract, but kind of beautiful with all of the, the verbiage of what that narrative competence means, metabolize, absorb, and be moved by. Um, I like to think of narrative medicine as the intersection of healthcare with storytelling in all mediums of storytelling, whether that's prose and writing most commonly, but also poetry and visual arts and reflective thinking and music. If we take a moment to think about the ways that stories exist in medicine, and in our work in our daily work as doctors, the most obvious to me is a patient's story, uh, that which they come to us with. They're short stories of illness that's set within like the larger arc of their life that progresses over time. And Each day we have the ability to view their interactions with us and their stories as a rich and deep narrative if we so choose. There's also then the component of processing and reinterpretation and retelling of patient stories in our own minds, in our notes and documentation, and in our conversations with colleagues. For example, staffing a case with an attending, we're telling the patient's story. When we are calling a consult, we're again pitching their story, or just chatting about something interesting that happened that day. And then finally, there's the angle of our own story as physicians, thinking of the challenges, the plot points, the joy, the growth that happens day to day as we're touched by our own work. So the definition of narrative competence raises this distinction between disease and illness. Disease is biomedical. It is a problem that can be explored and addressed by science, whereas illness encompasses the human experience of disease. Arthur Kleinman is a psychiatrist and a medical anthropologist, and his work really centers around this idea. And he writes that each patient brings to their practitioner a story. That story enmeshes the disease in a web of meanings that make sense only in the context of a particular life. He argues, and I tend to agree, that capable clinicians are able to diagnose and treat disease, period. But excellent clinicians must be able to address disease while also being mindful to care for psychological and social experiences that our patients have as it pertains to their illness, and they come to us seeking help for. There are three principles of narrative medicine that I wanted to highlight here, just for a bit of mechanics to the practice too. The first is this principle of attention, and this is the idea of practicing presence and awareness. It is listening to patient stories, to observe them, and also the idea of identifying our own stories, kind of the tangent I took on the first slide of saying, here are all of the ways that stories manifest in our day-to-day. The second principle would be representation, which is identifying meaning that's derived from those experiences, how we portray and then convey stories to colleagues, patients, families, and to ourselves. And then the last tenet is affiliation, and this is the meaning making. So creating connection from these experiences, again, with patients, colleagues, and with ourselves too. There are tons of ways that narrative practice takes place. Because of the intrinsic benefit of the group nature and sharing of narrative work, writing groups or book clubs are very common, where people can come together to share writing, to share in discussing different pieces, book clubs again, for example, and there's feedback and growth and connectedness all intrinsic to that. There are more structured workshops, such as those taught at like Columbia University example, kind of the birthplace of narrative medicine. And that's really focused on teaching skills and definitions. And then for others, the narrative practice can be really solitary. People find meaning in writing and reflection on their own. And then finally, there are lots of examples of how this is integrated into medical education, both at the undergrad and graduate level. Today kind of be an example of that. And I'll get into a little bit, but specifically within the space of education and training, there are ways to promote professional identity formation intrinsic to some of these practices. Okay. So we'll ask the question, or you all may ask kind of why is this important? In our world of allopathic medicine, something must be studied for it to be legitimate. So I collated on this slide here just a couple of evidence-based benefits of narrative medicine practices and exercises. From the clinician standpoint, studies have looked at narrative or artistic interventions. And those are things that are given to clinicians or trainees, often reading a piece of writing together or poetry together, looking at a piece of art, and then completing a writing exercise or discussing and reflecting thereafter. There was one study that I saw based out of an OBGYN residency program. It was a longitudinal workshop where each week the residents would engage in a 1 hour long session of reading short pieces, writing reflectively, and then discussing as a group. Some of those studies together have found greater rates of preserved empathy among providers, reduced compassion fatigue and burnout, and then increased teamwork, and then that promotion of professional identity formation, which applies both to the trainee and I guess post-trainee phases. For patients themselves, narrative exercises such as writing about stressful or meaningful experiences have been shown to improve quality of life metrics in some cases. They can even help reduce symptom burden that's been studied in folks with chronic inflammatory conditions or even metastatic cancers. And then promoting meaning too, as they traverse the arc of their illness. And the last thing I want to share here is a cool exercise that I learned about that's called the 3-minute mental makeover. This was, again, a narrative intervention that took place during an outpatient visit, and physicians and their patients took a few minutes to simultaneously write responses to 3 prompts. And those were writing, what are you grateful for? What are 3 hopes that you have? And then to write your life story in 6 words. The doctor and the patient then shared their responses with each other in real time. And the study found that patients reported greater levels of teamwork and connection with their providers and lower levels of stress as a result of doing that exercise. And the clinicians found that that they improved their communication with their patients and patients' families, and that these findings were durable for 6 months after the intervention. And a lot of patients noted it to be a new coping strategy that they could use, particularly even for those who hadn't been writing beforehand. I think so. Anyway, that is just I thought was a pretty neat and pretty low burden way to integrate narrative medicine with patients to improve that doctor-patient relationship. Okay. Those are all the slides that I have. So let's move on to some writing. This will be the workshop component. So please grab something to write with, whether that's pen and paper. You can write on your computer, on your phone, truly, however you so please. I will be the timekeeper here, but format will be we'll have 2 activities. There will be a warm-up activity where we'll just do a free writing exercise for 2 minutes, and I'll start the timer and let you know when it's done. I'll give a prompt in a second and just let flow what comes to mind. The second will be I will read an excerpt of a narrative piece by Louise Aronson. It's called Why Geriatrics. She's a UCSF geriatrician. I came across this piece when I was on the residency interview trail, actually, during one of my interviews, and it really stood out to me as like a beautiful reflection on why someone does what they do, why they're motivated by their work. So I, again, searching for something that was comforting, thought to bring this piece today. And then we'll have 5 minutes to write in response there. And then Javel will help us break into breakout rooms, and then we'll have some small group sharing, and I have some discussion prompts too that we can put in the chat. Okay. Some ground rules today. So for the writing itself, write freely, whatever comes to your mind. The R2s did a bit of narrative medicine at a professional development day, and Naomi Shaikh told us just like stream of consciousness, go wherever your mind takes you. This is not the time to edit, so try not to scratch out or rewrite. Just let the writing happen and have fun with it. It can be a bit intimidating, admittedly, but we'll have fun. And then for the sharing component, sharing one's writing is really vulnerable. I'm going to ask that everyone read exactly what they wrote and not skirting around that, but embrace that vulnerability today. And then for those who are sharing, assume from your colleagues that there's good intention coming from commentary and discussion. And then for the discussion, I ask that those in the group listen deeply and respond without judgment, maintain that mutual respect that we come to these groups with, and then maintain confidentiality, of course, as we're sharing personal information. Are there questions before we move on to the first activity? Okay, great. So the prompt here, finish this sentence and keep going. I really ought to eat more blank. Halfway through. Okay, last couple of seconds. Get your final words on paper. Okay, time's up. Perfect. Doesn't need to be a formally finished sentence. We're just going to move on. Okay, feeling okay? Thumbs up? Stressed maybe? Kind of? Okay, wonderful. Um, so activity number 2. So I'll read uh, some of the piece here, why geriatrics, and then we can talk. I'll share the writing prompt from there, okay? Okay, so Why Geriatrics by Louise Aronson. I blame the hats. Mrs. Chin's red and gold San Francisco 49ers cap pulled low over her toothless, smiling face despite the late September heat wave. The jangle of World War II combat medals as Antonio Annarico held his faded green fedora to his chest and bowed from the waist when I came through the exam room door. Annabelle Winter's golf visors, a different pastel color for each day of the week, matched to her pressed sweatsuits and socks by the private duty aides her son hired for her comfort and convenience. Can I admit that I never intended to become a geriatrician? That the hat seduced me, presented as they did, as they still do, in a beguiling multiplicity of shapes and persuasions, that I've seen it all. Beloved, greasy baseball caps, Oakland A's or Giants mostly. Wide-brimmed straw hats pinned with painted silk flowers or tied with bright cloth ribbons, a triangular black hat with a wood smoke smell, and red pom-poms at the corners. Yarmulkes, simple and black or satiny and intricately embroidered, exotic scarves wrapped around head and hair in accordance with tradition or with idiosyncratic flourish, the occasional cowboy hat or beret. Can I also admit that this list is only the beginning? And what about the details I omit when telling duly de-identified stories to friends and family? That Annabelle's Winters wore not only pastel visors, but also, at her son's insistence, pink lipstick and inch-long glittery latex nails, the only ones on the maximum assist end-stage dementia unit of the nursing home where she lived. That Antonio Enrico, repeatedly homeless, was found frozen, dead in a donut shop entryway one winter night as I drank sangria and feasted on small plates of garlic vegetables and lightly battered mollusks at a restaurant less than half a mile away. That I followed Mrs. Chin's red and gold 49ers watch cap from the emergency department where it was just visible over the rim of her pillow upstairs to the medical floor and then into the intensive care unit where it drooped from her granddaughter's purse as I explained to the family that she was dying. May I admit too that I love this work, that I have never in years of caring for the ancient and frail considered what a surgeon acquaintance once said he'd do if he had my job: put a bicycle helmet over his head to contain the damage, bite down on the barrel of a 9mm handgun and pull the trigger. That if, on the other hand, my patients were like most of his, asleep during his most significant interactions with them, reduced to body parts in need of carving with which I lose patience before filling each waiting plate at Christmas, and the couture skills which interest me so little that I have a hamper of clothes that have waited months and sometimes years for a new button or hem, that I might need an antidepressant, if not a handgun. In truth, I prefer the hats to most other parts of medicine, which is good, because they just keep coming, each one by now familiar and each one endangered, precious, and unique. Okay. Um, Second writing prompt that we have today will be 5 minutes long. I will set a timer again. And here they are. We have two possible choices. One, what is your hat? Share an example. And then the second option would be, when is the last time you saw humanity in a patient? Think for a second and then get writing. 5 minutes. Just about one more minute. All right. Go ahead and get your final words on paper. Okay. So now we'll go ahead and move into breakout rooms. 20 minutes is an overestimation, but we'll aim for just about 10, Javel, if that works. We'll start by sharing activity one responses, just as an icebreaker, and then go ahead and share your response to activity two, which is this one, okay? And then just talk with whatever comes up. Some ideas to discuss would be, what do the stories bring up for you? Do you have similar experiences, etc.? Okay. Questions before we go? Okay.
All right. So I've given you 10 minutes in the breakouts, and when you see the timer hit 0, you'll then have an additional 30 seconds to kind of finish what you're saying before it spits you back out into the main room. Okay. Connor, did you want to join a room? I didn't assign you one.
I would love to.
You know, too? Okay.
Thanks.
Chicken. Room two. Amanda, let me know if you have any issues getting into your breakout room. Let's see. Let me move him to 6. 6. Yeah. Amanda, can you hear me? Okay. Seconds. Let's get you back.
Looking good? Okay, wonderful. I hope that was a nice little joyful couple minutes for you all. Um, so in conclusion, today, thank you all for being here. Narrative competence, to reiterate, the idea to absorb, metabolize, interpret, and be moved by stories of illness, illness being distinctly different from disease itself. We talked a bit about attention and representation and affiliation as principal components of what a narrative practice looks like. Um, and shared briefly about how narrative interventions can reduce burnout, promote empathy, and hopefully, as you all felt a little bit today, feel like there is some increased meaning in the work that we do, and that can be translated to patients too. I wanted to spend the last couple of minutes here just sharing a bit about where one can find additional narrative pieces. There are, as many may know, journals, whether it's JAMA, New England, Annals, that have a section specifically devoted to people submitting narrative pieces. And then there are additional journals specifically for narrative medicine, like Intima and UCLA Beat. I've also gotten into recently podcasts like The Human Doctor that I think Dr. Adamson mentioned a while back, and that's a storytelling-based podcast with some internists out of UCSF and Emory. And then the comics on the slide, two that I found and just like to kind of check out on every now and again. Ink Vessel is a palliative doctor out of Johns Hopkins, and then Shirley Worrell is a cardiologist who has a really fun Instagram page. I was hoping to leave this up. I feel like crowdsourcing ideas for what books and authors and articles and podcasts and art you like would be really nice to then just like share with one another too. As we wind down, I was going to leave this slide up so that people could hop onto Slido, which should be active. And then just like drop in there whatever you'd like to share with colleagues, things that you've enjoyed reading or listening to. And then I can like share this list as well so you have a go-to in the future. That's all that I have today. So I'm happy to take questions or hear reflections or reactions from today's session. Thank you.
Thanks, Connor. This was great.
Thanks, Anna.
Lots of thanks in the chat as well.